And we need to make sure that you can't just walk away from them because you say, well, they've offended, they've sinned, and we don't owe them anything. You've got to pay one way or another, and Washington State data makes it clear that better that you deal with this in a comprehensive way so that you don't pay in the long run.
So thank you, Dr. Clark. The point, and it's come out through all the presentations today about how these are people who are going to, they are in the community, they are of the community. It's been made over and over again. I think it's a very important one because the degree to which they spend time one day, less than 1 day, 1 week, whatever, the rest of the time, that's 10 days and whatever, and 355 days in the community. So let's pay attention to that, and I think that's a very valid point. So let's presume alacrity and dispatch. I like that. Even with alacrity and dispatch at the federal level, as has been pointed out by Joan and by Dave, there is a lot of variation across the states and across the county, even at the county level. So, and as was suggested as well by Sarah in her earlier remarks about the legislation and as we wait for regulations, what's it going to mean? There are a lot of choices that states and health plans, states and counties, jurisdictions outside of Washington are going to have the opportunity to make. And so I'm curious about what our expectations, either panelists or people out in the audience, what are the expectations for the choices that are going to be made by states and plans across the country? And this is your opportunity to get that little blue card out that I was bragging about before she's got one, or to stand up when somebody will get you a microphone. But first, I'll give you and anybody here an opportunity just to comment on what you think you might expect on the alacrity and dispatch front from states out there across the country.
Well, I can share that, clearly one of the reasons I am no longer in state government is that we had a change of administration. And our new elected governor is actually one of the attorney generals who is suing over the Health Care Reform Act. And so I think that I'm sure that I'm not alone in many states where there's been a change perhaps in some of the elected officials about what it does mean. I think there is a lot of wisdom, however, about many of the Medicaid proposals really need to go forward and are likely to go forward. The areas of most contention seem to be around the individual purchase or the requirement that an individual must have health insurance. And so I think that one is that we don't want the environment to chill the activities that are going forward. So I think one message is get invested and get involved. There is absolutely a lot of decisions that will get made at the state level. There is a lot of infrastructure being created in every state with healthcare reform gurus who are coming to say, here's the kinds of questions. What is of some concern is that many times behavioral health or the populations of folks in corrections or others, we often don't get acknowledged until someone will go, oh, that's right. They're the ones who are costing us all the money. They're the ones who are creating all the community challenges. These are the folks that we have to be most concerned about. So being engaged early in an advocacy position and being able to come to the table with some solutions around how it is that we can interface and really maximize. I think there is absolute potential to build off the data systems to say, if in fact, because we know for those of us who are in the field, we know that if we do early intervention and screening and prevention and treatment, we impact homelessness, jail, family issues, school outcomes. We know it. We have not been able to prove it as successfully as we need to make the argument. It is why David's experience in Washington and others is so important. And so artificial barriers such as some of the confidentiality challenges where we can't share data, so we just should talk about that. Some of the things that we haven't been able to prove the point because of some obstacles, I think have to get overcome, but we can make the case. And this is a tremendous opportunity to bring in prevention under Medicaid, to even expand our purview and make a tremendous amount of difference.
I would just say, and I do have a couple of questions here, that we work with states across the country, and there are states that are facing various political changes, et cetera, but the overwhelming sense that we have is that every state is pursuing the development of its response to health care reform. They have to, and they were doing that before the elections. They're going to do it after the elections. There are too many things that they have to do in order to be in a position to take advantage of whatever opportunities that there may be. And I agree that Medicaid in particular is, the Medicaid expansion is one that's almost a, I don't want to make predictions, but it's very likely to proceed to a considerable degree, and states recognize that. So, and there clearly, as others have pointed out earlier, there are big opportunities with respect to funding, at least through 2019 or 2020 and beyond, with respect to this population for the states. So it's moving forward. I agree with you. There is a question here about the data side, and actually, Dr. Redmond, there are a lot of questions here about the data side in this blue card. And I do want to give Allison a chance to just talk a little bit about what she's seen in Pennsylvania with respect to data sharing and how important the data sharing is when you're talking about multiple systems trying to collaborate.
Sure.
Sure, Allison, go ahead.
Yeah.
You only have two
No, that's right.
Pennsylvanians
Yeah, no
talking.
pressure. I only have, the current and former deputies here. CHCS has been working in close partnership with Pennsylvania on a very innovative project to improve physical and behavioral health integration. Further context to the background that Joan provided, the areas in Pennsylvania where we're working are capitated managed care environments with carved out managed behavioral health and mandatory separately capitated physical health. We are working in 2 areas of the state. And again, against all odds, some would say, given the very separate systems for managing physical and behavioral health here, to integrate care specifically for adults with serious mental illness. The project is about 1.5 years on its way, and it's an amazingly successful project with huge opportunity and a lot of momentum potentially to carry it statewide in the future. I won't commit anybody in the room to anything. But clearly, I'd say the key takeaways from this project are there is tremendous possibility when you align incentives for partners across systems, which leadership in Pennsylvania has been able to do here by basically putting new money on the table in the form of performance incentives tied to care coordination across systems and integration across systems. So number 1, aligning incentives, and 2, requiring exchange of information. Consent and privacy is a big issue. The state has, I think, addressed this in a very promising way by allowing kind of multiple levels of coordination based on levels of consent. So full integration, sharing of information, particularly on the substance abuse side, is only enabled when an individual beneficiary agrees to sign up for full information sharing across all systems. But there are things that can be integrated and coordinated even when that doesn't occur. So things like sharing information across systems when somebody ends up in the hospital, making sure that folks on the behavioral health side know about that, that various providers in both systems know about that. That can easily be extended outside of the healthcare and arena to include criminal justice partners as we think about broadening this type of collaboration. And so models like this, again, focus on aligning incentives and encouraging information exchange and stratifying resources to allow different levels of touch based on the one hand, levels of consent to participate as well as levels of severity and need are critical to enabling, the most effective resource use for these.
I'd like to dovetail on that with regard to the issue of 42 CFR Part 2, which often gets misinterpreted and misunderstood. It does have some flexibility built into it to allow for qualified service organization agreements in order to have information sharing. There are also some exceptions to confidentiality. For instance, someone who is on parole, probation, or under the jurisdiction of the criminal justice system they can sign waivers to the judge or to the prosecutor, and that consent persists as long as that person remains under the jurisdiction of the criminal justice system. Well, the key issue for the substance abuse and mental health communities these days with regard to health information exchange is that most mental health and substance abuse providers and institutions, that's both professional and institutional providers, are not meaningful users under the HITECH Act. So they will not be eligible for the bulk of the incentives, the multi-millions of dollars of incentives that are going into stimulating information exchange. We are working with the Office of the National Coordinator of Health Information Technology to address that issue. Joy Pritz is working for David Blumenthal, is very much interested in privacy. SAMHSA is committed to working with the issue of privacy and making sure that 42 CFR Part 2 is not a barrier to information exchange. We're going to be working with the Department of Justice in terms of information exchange. There are states like Maryland where the state authorities have worked out a working relationship with the jails so they can exchange information between the substance abuse treatment programs and the jails. So if indeed people put their minds to it, there are very few barriers. The most important barrier is the lack of willingness to deal with the issue, and as I pointed out earlier, stigma, people not wanting to deal with the issue. We have worked in partnership. Melody Heaps is in the audience in terms of educating judges. We need to use our existing infrastructure to make sure that all partners involved understand the potential for the expanded care under Medicaid. So community coalitions, training providers in the community so that indeed they recognize that there's potential here that will help them, their families, and their communities. And so I think that's a key issue because that helps the data. Some vendors say, well, I don't really want to deal with mental health and substance abuse, so confidentiality is a barrier, when in fact, if they could use their brains to create the software, they could say, oh yeah, we could deal with that. And in fact, we're finding that that is the case. A lot of the objections to information exchange come from, I'm too lazy to use my imagination and innovation and creativity to do this, and I don't want to be bothered.
I think Dr. Clark is suggesting that you're lacking alacrity and dispatch, right? And the point around sharing information, and I want to underscore it there, and I appreciate the point about the ARA and high tech and the opportunities for meaningful use. And I was with somebody from ASPE yesterday who said that you're pushing that back up the hill to try and get others to partake in that. But I also want to underscore what Allison said about data sharing at point of hospital entry. The reason they do it is because they both lose money. There's gain sharing. They both lose money if they don't succeed. That's one of the measures, the performance measures, for being successful. And again, there are 3 Pennsylvania people who know more about this than I do, but that is something you got to use. And this is in Pennsylvania with managed care organizations. There's a question here about managed care organizations, and the ACA has a fair amount of emphasis on accountable care organizations. I'm not sure how many people in this audience would like to stand up and define what an ACO is. I'm certainly not going to stand up and do that, but it is. Sarah's passing on that one too. But there is a push toward accountable care organizations, and how does that play within the context of of managed care organizations, and the fact that it was suggested earlier that most of the expansion population is going to be put into managed care to the extent that managed care exists in a particular state. That's how they're going to go. Any comments on that, Joan?
Well, it is really a little daunting. There are accountable care organizations, there are health homes, there are accountable clinical homes. The acronym list continues to grow, but each have a role potentially. I think it goes back to trying to underscore where your communities are and what would be of most use. In Pennsylvania, Geisinger, if many of you have heard, Geisinger is in Danville, Pennsylvania. It's a small community. It is considered it's an integrated health system that it's an insurer as well as a provider. The system I come from, which is UPMC Health Systems, of which community care is a nonprofit component, could be morphed into an accountable clinical home or accountable care organization that has kind of total responsibility. I think part of the challenge we have is, again, in our system in Pennsylvania, we have a county-based human services strategy where we could contract with an accountable care organization in theory, but it feels duplicative. It feels like in our system that may not be the place we want to go for behavioral health. And it doesn't mean that we couldn't coordinate it, but we do worry about one of the strengths and one of the things that local communities, you know, my perspective when I was deputy and now in my new job is I want all the money. You know, I mean, that's really the bottom. I want all the money. You know, you want to have resources, and we've gone to other states, and as I've learned about other states, I worry that they have a carve up instead of a carve out. They have, you know, there's complicated rules. You have SSI folks over here, and you have people with substance use over here, and you have this one. And really, the strategies are consistency in the treatment approaches, consistency in the interventions and what works, the essential benefit conversation, et cetera, but it's also consistency by payer. So that, you know, that the discriminatory, what we try to overcome with parity is the discrimination that many people felt because we didn't have consistency in that approach. So if we could get to those kinds of things, any of those models could work in some places. It is really the strategy to understand in your community, in your state, is that a role? And then how does behavioral health fit? And the obligation as to whether or not it's part of the accountable care organization or separate from it, will it actually meet the test for good clinical services, good intervention, and be part of a community system that will interface with jails, schools, et cetera? I think that's the key.
David, do you want to comment at all from Washington? Is it going to be managed care? You've been down the road with Basic Health Plan. Is it going to be managed care, the ACO?
Well, I've got someone in the audience who would know much better than me. I take data questions in Washington legislature. but I would say it's clear we're moving in the direction of managed care for our, for SSI-related populations. Those are moving towards managed care, and I would certainly expect that the low-income expansion population is going to move in that direction.
Okay. And we'll get, Marianne will have a chance to talk a little bit later. We'll probably get back to that. I have a question here about the opportunities in the ACA to help states leverage greater housing opportunities for homeless justice-involved people with health and behavioral health challenges. I think that's come up. Corporation for Supportive Housing come up a couple places. And do you, anybody on the panel or anybody out there who would like to comment on what the ACA has in it for encouraging these kinds of collaborations in supportive housing? I believe there is such a provision. And Sarah, I might turn to you if I don't get buy-in from... all right. Well, the question is a good question. We don't have a good answer. But we'll get back to you on that. Are there other questions out there in the audience? Yes, right here, ma'am. Right here? Yes. Names, rank, serial number, question.
I wanted to sort of shift the discussion a little more explicitly towards... I'm going to do that second.
Okay, thank you.
Sort of, I'm setting the stage here. To sort of look at workforce development, and the judge mentioned capacity building, and get kind of some comments and put an offer, I guess, on the table. I'm Lynetta Albright, director of the Great Lakes Addiction Technology Transfer Center, and we are one of 14 regional centers that cover the entire country. SAMHSA, particularly Dr. Clark, and CSAT has funded this national network for 17 years now. And our focus for the addiction treatment field primarily has been around training and helping the field adopt evidence-based practices, systems change, more recently in the last 5 years around recovery, helping states with recovery-oriented systems of care, many of the things that have been talked about today. Allison's paper talks about one of the states that they were involved in recovery-oriented system of care transformation, the work that they've been doing. To a smaller extent, there are two of our ATTCs that have done workforce development with criminal justice systems. Our ATTC with Illinois Task, guiding our criminal justice work. And I think that Some of my thoughts around the discussion that I've experienced in the last 11 years when we have these big efforts, workforce development, capacity building, infrastructure development sort of gets left off the planning table. And then once we get started with our strategic plans, we sort of try and catch up to how are these things actually going to happen? How are the attitudes actually going to change in the systems? So some of my thoughts, I guess my question for the national conveners today and others who don't know the ATTCs is to kind of ask you what you're thinking strategically around workforce development, capacity building as it relates to getting some of the goals met. One of the goals in the healthcare reforms implementation plan talked about facilitating collaboration. That's something else that is part of our efforts with technology transfer. So I would like to hear, I know the judge is no longer on the panel, and others there to kind of tell me what you're thinking or share with us where you see workforce development, capacity building at the very front end of this work, I guess. So more explicit discussion.
Okay, I think that a great question, and I'm probably going to ask Dr. Clark if he would like to say anything about it, but I also want to acknowledge that we were getting into that in the next session this afternoon. Turning to you, Dr. Clark, to answer on behalf of the entire panel, especially the data man who doesn't have anything to say about this, Dr. Clark.
Well, we recognize that workforce development, as others have pointed out, and in the papers, you're going to need to have people who can do the assessments and work with the clients. Because there's another issue that we didn't have time to talk about, that is eligibility and enrollment. If you can build it, they don't necessarily have to come. And so part of the issue is you do need to have that. So we're working with HRSA. Pam Hyde is working with Howard Cole, who's the Assistant Secretary of Health, on a Behavioral Health Coordinating Council. And Mary Wakefield has tasked HRSA to work closely with SAMHSA on this issue of making sure that we're able to address the issue of workforce development. And there is some workforce development in the ACA in terms of behavioral health training, because someone's going to have the knowledge and skills to achieve the goal and objective. So it is an issue. There's not a lot of money there. There is some money. We're working with HRSA. We're working with the Office of National Drug Control Policy in order to facilitate that from a substance abuse perspective, and with HRSA, both substance abuse and mental health perspective, to deal with this issue.
Okay, very legitimate issue. Quick comments from the Justice and from Sarah, and then that's going to wrap us.
A very small project we're doing in Ohio, but I think it's something we could maybe think of nationally for workforce development, is we actually make a presentation to the psychiatric residents at 4 of our state universities now, and train them on what is a mental health court, what are the substance abuse, mental health issues. We actually take them to a drug court. Maybe now is the time to start getting into all of these organizations that do training, all the colleges, all the campuses, and start training on ACA, on what's coming down, and get them while they're young and vulnerable and impressionable, and see if we can start there.
Pass that right back to Sarah.
Yeah, the workforce development issues, there's 2 things to say about it. One, there's a whole title of the ACA that is developed to all kinds of primary care development, not just mental health. But hearkening back to what the Justice said, the difference between authorizing funds, however much they may be, and appropriating them is a huge gap, and that's too grim to talk about right this minute. But in addition, there is the issue of a lot of them are incentives for people to go to school. And so already you're going to have a gap between when these people are actually ready to go. And the final thing I wanted to say was something we haven't mentioned, which is the reauthorization of the Indian Health Care Improvement Act amendments. And there is a lot of workforce development in the mental health area there, because there's an entire title of the Indian Health Care Improvement Acts that are about behavioral health and setting up a new system. We haven't even touched on that, but that's important to keep in mind too.
Okay, well, I think that we're going to have to do the wrap. There are more questions, Steve, but you're stepping up here to take me away, right? Yeah. So I want to thank this panel. This is an incredibly rich discussion. It parallels what occurred earlier. It's covering a lot of space. We got into just at the end here, the Indian Health Service. Obviously, lots more to talk about as we go forward. But let's thank this group. Very, very rich panel.
Thank you, Steve, and thank you, panel. I want to make sure that everyone understands how many resources go in to planning a day like this, and they're not just the philanthropic resources for which we thank the Robert Wood Johnson Foundation, the Jacob and Valeria Langlois Foundation, the intellectual resources that all of the authors and the panelists have put into it, and I particularly, Dave Mancuso, I particularly want to thank you for your data that demonstrates that the investment that we make in providing Medicaid services for substance-dependent folks saves us money in the long run for Medicaid. I think that's just an incredible intellectual platform for us to build on as we go out in our work. I also want to thank the communication resources of Burness Communication, Ben Milder, Mary Darby, and Julia Kaiser, and all of the Cochs resources, Nancy Torrey for putting the energy into managing this project, Ben Colburn, Joseph Fisher, Maxwell Cuddy, Nick Dare for all their work in putting logistics together. And now we're going to get to eat lunch, for which I get to thank Melody Heaps. Melody?
Thank you. Hi, I'm Melody Heaps, President Emeritus of TASC, and I've had the privilege of being a consultant on this project working with Cochs. And I have to say my brain is about ready to explode. And that is, I think, a wonderful statement, because it is with great appreciation that I want to thank the Robert Wood Johnson Foundation, the Langworth Foundation, and of course the extraordinary work of Cochs to bring us together, because in my work it would have taken us years in our various iterations as we pass through each other and by each other to have these discussions. And while we may not be strange bedfellows, we certainly aren't all in the same room at the same time. And I think you have jump-started this discussion in terms of timing with alacrity and dispatch in ways that would not have happened. So I am so grateful for you, and thank you. The Center for Health and Justice at TASC is the policy and advocacy group, and under its leadership and its president of TASC, Pam Rodriguez, they are happy to tell you that lunch is being provided by them as a means of saying to you this is a very, very important issue. TASC has for the last 35 years been involved in providing diversion and sentencing alternatives and treatment for individuals in the criminal justice, from arrest all the way through incarceration and parole. And so we believe this is the one potential hope we've had on the horizon for expanding the resources for treatment, moving people out of our prisons and jails, and bringing real justice to the United States in terms of our judicial and criminal justice policies. Now, with, again, alacrity and dispatch, which seemed to be the theme of this conference, I have been told to give you instructions about lunch, but I'm not supposed to just tell you. I have to read it from an email that has been provided me. I think Steve Rosenberg was sure I was going to tell you to go back to the Hyatt, enjoy yourself, and not show up. So I am about to read what so there you go. Lunch will be provided at the Thunder Grill, which is actually at the opposite front end of this organization. So walk down the stairs, walk across. It will be on the balcony and mezzanine level. Lunch and soft drinks are going to be awaiting at your table. There will be a coffee bar and hot drinks also provided. The Thunder Grill, again, is across the way at Union Station. Do not go out of Union Station. We hope that you will use this opportunity. I'm reading this from my BlackBerry. As an opportunity to network and mingle with your peers, that many different issues can be brought up and bring us together. And most importantly, we will be reconvening precisely at 1:30 back here. So have a good lunch. Thank you.